We're back for part 3 of chapter 39, and we're talking about hematological conditions, talking about polycythemia, and that is noted with a hematocrit greater than 65. It is associated with diabetes, congenital heart disease, fetal hypoxia. Clinically, you may see a diabetic mom, hypoglycemia in baby. It can be seen with twin-to-twin transfusion recipients. If there's been a delay in clamping the umbilical cord, if there's been cyanosis or persistent fetal circulation, tachypnea and respiratory distress, and in post-mature infants or small gestational age infants. Management of these little ones is found on table 39-6, along with some other perinatal disorders. It's the very bottom one on that table. These infants can have some speech deficits, some abnormal fine motor control, some intelligence issues. Next, let's talk about some hemorrhagic diseases in the newborn. The first is severe transient deficiencies in vitamin K. So we're having some clotting factor issues and bleeding. Often seen with moms who have used anticonvulsants. May be noted in babies with prematurity. Seen with babies that are exclusively breastfed without vitamin K supplementation, or infants that did not receive parenteral vitamin K at birth. Can be seen with neonatal hepatitis or biliary atresia. Also may be seen in babies with GI, nasal, or intracranial bleeding. Lab test would be ordered and check your PT. Coag studies and a PTT differential diagnosis are based on the results of if you have DIC or other bleeding disorders. Management would include IV administration of vitamin K. For management, if this was a home birth, need to assure that vitamin K was given. And the prognosis is dependent on the site of bleeding and the extent of bleeding. So anemia in this age group is hemoglobin hematocrit less than the normal range based on birth and postnatal age. Anemia at birth typically occurs secondary to acute blood loss before or during delivery. This blood loss can be external, which could be GI, circumcision, site issues, umbilical stump. It could be internal, it could be a fracture, cephalohematoma, pulmonary hemorrhage, or it could be secondary to hemolysis or congenital aplastic or hypoplastic anemia. Management would be based on the cause and the symptoms, and treatment would be determined from there. So blood in vomit or stool is often caused by ingestion of maternal blood, and it's important to differentiate the blood of mom from the infant's blood. And this is done by doing the APT test. So management would be based on the source of the blood. If it's no fetal blood noted, and it's maternal, then there's no need to treat. Next, let's talk about jaundice, which we know is accumulation of bilirubin under the skin. There are a couple of different types of jaundice that we're going to discuss. Physiological jaundice, which is most common. It rises on the 3rd day of life and declines on day 12 through 15. Breast milk jaundice from infrequent or insufficient breast milk to flush it out. And non-physiological jaundice is seen at less than 24 hours and may last more than 8 days. In the book on page 1111, table 39-8, there is a detailed chart with diagnostic features of the various types of neonatal jaundice. I encourage you to look at that. Causes include an increased rate of hemolysis, an ABO-RH incompatibility, abnormal red cell shapes, decreased rate of conjugation, and abnormalities of excretion or absorption. Clinically, risk factors for severe hyperbilirubinemia, hemolytic disease, anemia, inborn errors of metabolism, early or severe jaundice, liver disease, ABO or RH incompatibilities with previous pregnancies, sepsis risk, or a macrosomic infant of a diabetic mother. On physical exam, the face is often the first area impacted, then shoulders, chest, and abdomen starts at the top and works its way down. The accuracy of estimating a level is poor based on skin color. Petechiae and bruising may be noted. There may be hepatosplenomegalia. The baby may show signs of lethargy, poor tone, a poor feeder. There could be diminished tendon reflexes, respiratory distress, failure to suck, bulging fontanelle seizures. Diagnostic studies include TCB, and these are all assessing for total bilirubin levels, blood types, H&H, retic count. So an elevated indirect bili with normal retic count and negative Coombs could be the result of physiological breast milk or congenital non-hemolytic jaundice. An elevated indirect bili with increased retic count could be increased hemolysis, and an elevated indirect or direct with negative Coombs or normal reticulocytes could be caused by hepatitis, metabolic abnormalities, biliary atresia, GI, pancreatic obstruction, sepsis, and drugs. If a pathological jaundice has been determined, it's going to require an in-depth workup. Management and prevention is going to include promoting breastfeeding, discouraging water use, phototherapy. Important to continue breastfeeding during phototherapy, and exchange transfusion guidelines. Exchange transfusion, there are AAP practice guidelines that you can consult if necessary. Next, let's talk about infections in the newborn. There's 3 mechanisms for acquiring a neonatal infection, whether it be transplacental, vertical, horizontal. Risk factors for sepsis can include early or prolonged rupture of membranes, and then maternal fever. Organisms are going to quickly invade the systemic circulation in a little one, and your newborn may deteriorate quickly. So if you have newborns with significant risk factors, there is a box on page 1116 in the book, 39-5, which refers to neonatal sepsis, which gives a good breakdown of what you would need for an H&P, physical exam, lab values, and management. Next, let's talk about toxoplasmosis, which is an infection of the Toxoplasma gondii. Most often, the T. gondii infects warm-blooded animals, particularly cats, but humans can be infected by consumption of poorly cooked meats or accidental ingestion of the oocytes from the soil or contaminated food. Clinically, you may see a baby with prematurity or low APGAR scores. They may have Babies with congenital infections may be symptomatic at birth in approximately 70 to 90% of the cases, but they may have jaundice, anemia, hepatosplenomegalia. They may have microcephaly. So diagnostic studies would include CT of the brain, which may show calcifications or hydrocephalus. They may have blood counts that show high protein, low glucose. There may need to be the need for a spinal tap. You also would want to associate your assess your immunoglobulins, your IgG, IgM, IgA, and IgE. Treatment would include pyrimethamine plus sulfadiazine up to 1 year. There may be permanent impairment of vision and hearing and cognitive function if severe at birth. So it's important to avoid handling raw meat or cleaning up cat litter while pregnant. Let's next talk about rubella, which is transmitted by person-to-person contact, and the virus infects the placenta and is transferred to the baby. It frequently in the winter and spring. Clinically, on your history, you may have a mom who had a maternal infection before 16 weeks of gestation. Her titers were negative at the beginning of her pregnancy, and many as 50% of moms are asymptomatic. Clinically, the baby may be asymptomatic in the newborn period. There could be cataract or glaucoma, hearing loss. There could be blueberry muffin type lesions of the skin. To diagnose, they're going to isolate the virus from a swab through the nasopharyngeal, conjunctivae, urine, stool, CSF, and there'll be measures of serum immunoglobulins like we talked about. Management includes no specific drug therapy. They'll be monitoring for developmental, auditory, visual, and medical needs. And then rubella serology titers will be needed in all women of childbearing age. So let's talk briefly about cytomegalovirus CMV, and it is spread with contact with virus containing secretions or blood. So for little ones, that's transmission through the placenta. Clinically, you may find mom had an infection, but many women are asymptomatic, and as many as 90% of infected newborns are asymptomatic. You may see the condition in small gestational age babies, if they have jaundice, hepatosplenomegaly, if there's a petechial rash. You can also see cerebral calcifications or microcephaly. Diagnostic studies include isolating cell cultures from urine, saliva, or other body fluids. Ganciclovir may be helpful, but there's limited data conducted with infants to suggest the benefits on decreasing the progression of hearing impairment. Outcomes were poor with psychomotor retardation, microcephaly, hearing loss, seizures. Let's talk about Group B strep. It's the leading cause of sepsis from birth to 3 months of age. It can be colonized maternally in the GI-GU tract and have a vertical transmission. It is seen in high-risk deliveries, premature, small gestational age infants, very low birth weight infants, or prolonged rupture of membranes. Clinically, it's in babies less than 37 weeks gestation. Rupture of membranes greater than 18 hours, maternal fever during labor, or a previous sibling with GBS. Clinically, mom and baby may have tachycardia. There could be maternal leukocytosis. Uterus could be tender. There can be a foul-smelling amniotic fluid. On physical exam, your baby may be poor feeding, difficulty maintaining temperature. There could be apnea, tachypnea, cyanosis. These little ones may have seizures, lethargy, or bulging fontanelles. Diagnostic studies include blood cultures and CSF cultures. Management includes the use of ampicillin or Gent or IV penicillin G. You would want to consult with a pediatric infectious disease specialist, and it's important to screen all pregnant women for GBS from 35 to 37 weeks. The next is listeriosis, a foodborne disease. That's a transplacental transfer, or it could also be passed from aspiration or ingestion at delivery. You will note brown-stained amniotic fluid, generalized septic symptoms in the baby. There can be disseminated erythematous papules of the skin. Diagnostic studies would include cultures of blood, cerebral spinal fluid, meconium, and urine. The baby may have elevated protein, lower blood sugar, high leukocytes in the cerebral spinal fluid. Management includes IV AMP and Gent. IV AMP alone when there's a clinical response occurring. These little ones may be having intellectual disabilities, paralysis, and hydrocephalus can be noted. Next, let's talk about congenital varicella, which is the varicella zoster virus. We know that mom has to have a history of maternal chickenpox infection. We can see limb atrophy, scarring of the skin, issues with the eyes. Diagnosis of the varicella zoster virus is made by staining of vesicular scrapings. Acyclovir is given to pregnant moms with varicella, and if VCIG onset is within, you may see it within 5 days before or up to 48 hours after delivery. Let me rephrase that. So, the varicella zoster immunoglobulin is recommended for moms that are known to have varicella within 5 days before delivery and up to 48 hours after delivery. Sorry for that confusion. Next, let's talk about gonorrhea, which is acquired primarily during delivery. Clinically, you're going to have mom who had infection. Baby is going to possibly have conjunctivitis, septicemia, pneumonia, joint infection. Diagnostic studies would include culture of the eye exudate, and management would be single IM dose of Rocephin to moms with active gonorrhea and eye prophylaxis to all babies at birth. Chlamydia infection is caused by an obligate intracellular parasite, and it's the most common sexually transmitted infection, as we know, in the U.S. Mom has the infection. We can have issues with conjunctivitis in the first few days or weeks after birth, and pneumonia in 2 to 19 weeks after birth. Diagnostically, is we're going to test for the detection of the C. trichomonas virus. We'll do that with gram stain and culture of eye discharge, and then management will include oral erythromycin suspension. Almost done here. Syphilis. Syphilis testing is conducted on moms and required in all states. Clinical findings would include maternal infection, positive serology. Baby may have failure to thrive, restlessness, fevers. You would be consulting with an infectious disease doctor. Management would include penicillin G for confirmed cases or highly probable syphilis. And untreated syphilis can result in severe multiform organ involvement. Herpes simplex virus is a disseminated disease impacting the CNS. And also can impact the skin, the eyes, and the mouth. It's transmitted by direct contact with infected maternal genitalia during the birth process. The risk of neonatal infection is highest with primary genital infection at delivery. Clinically, the baby may have pneumonia, sepsis. You would do tissue cultures. Treatment would include acyclovir, eye drops, and the risk decreases by performing a C-section if there's signs of HSV. I'm going to let you read more about neonatal abstinence syndrome in the book, and we are going to think that, and then also read more about SIDS at the very end. Let you read on those last two topics, and that will conclude part 3 of chapter 39. Thank you.